intraoperatively during surgeries, and they're going to show some skills and some tricks which you can take with you. And to start off the session, I would invite Dr. Avninder Gupta, consultant ophthalmologist, senior consultant ophthalmologist at Center for Sight and Nayan Jyoti Hospital, Delhi. And his area of expertise has been complex VR surgeries, foreign bodies, and he is known for his innovations in surgical retina. So I would invite Dr. Gupta to start off the session.
Good morning, everybody. Thank you, Ritesh and Anirudh, for having me here. And it's nice to have our chief instructor. He has given the voiceover in this video. So it's a potpourri of cases of me and Ritesh. And
Ocular foreign bodies are seen in up to 40% of all open globe injuries. The presence of an intraocular foreign body in the vitreous cavity or retina is an ocular emergency and calls for an urgent removal in order to avoid the risk of endophthalmitis and its sequelae. Routine intraocular foreign body removal can be surgically challenging for any VR surgeon. Intraocular foreign bodies can be of various materials such as metal, wood, glass, plastic, and others, and their removal therefore could pose different challenges in each of these settings. This video depicts a series of surgical scenarios wherein surgeons have tried to remove intraocular foreign bodies of different size, shape, and nature using different kind of instrumentation. Case 1. A metallic intraocular foreign body with endophthalmitis. A 37-year-old male patient presented with sudden diminution of vision in the right eye following injury with a flying metallic object. His best corrected visual acuity at presentation was field plus PR accurate. He had a self-sealed corneal wound and a cataractous lens with signs of endophthalmitis. The wound, which was partially leaky, was repaired, and a 23-gauge pars plana vitrectomy was done. Initially, all the loose vitreous exudates were removed, following which a PVD induction was carried out with the help of a cutter. A 360-degree vitrectomy was completed and the metallic foreign body was freed from its vitreous attachments. An intraocular magnet was used to pick the foreign body from the surface of the retina. A careful attempt was made to align the foreign body with the long axis of the magnet to allow for easy removal through the port. But not all foreign body removals are as straightforward as this. The second case highlights the struggles of a surgeon while removing a larger metallic intraocular foreign body using a magnet and a forceps. After completing the vitrectomy to remove the vitreous hemorrhage, the foreign body was picked from the surface of the retina, again using an intraocular magnet. But as we were trying to take out the foreign body through the port, due to its large size, it got stuck at the vitreous base. This is a judgment error where a smaller port was made compared to the size of the foreign body. We tried multiple times but struggled and eventually had to enlarge the port using the MBR blade, and then the foreign body was slowly slid out off through the larger port. Both these cases were iron foreign bodies which are magnetic and were relatively easy to take out, but not all metals are so forgiving. The third case is a rare case of a retained copper intraocular foreign body which presented with severe retinal chalcosis and cataract.
6 months before and
The
got
patient's
operated
best
after
corrected
6
visual
months.
acuity at presentation
By the
was
time
6
he
by
came,
60
he had
with a
lot of,
cataractous lens
retinal
and a
changes.
retrolental
You
copper
see
wire.
here.
The fundus showed dense vitreous haze with a profuse optic disc and a reddish golden hue to the retina and the vitreous,
And you can see
suggestive
the
of chalcosis.
chalcosis changes on the
The
lens, and the
cataractus lens
capsule
was
was
removed by phacoemulsification, following which a complete vitrectomy was done, especially around the foreign body, which was first grabbed with a forceps and gently freed of all its vitreous attachments. Using a handshake technique with two forceps, the foreign body was aligned with its long axis in the axis of the forceps and was then gently removed through the 23-gauge pars
You can
plana
see the
port.
chalcosis changes in the retina, and in
Subsequently,
spite
the
of these
intraocular
changes,
lens was put in its place and the vitrectomy was completed. In spite of the signs of severe chalcosis on the retina, patient did recover to a best corrected visual acuity of 6/12 post-operatively. All the above cases were managed relatively comfortably because of a clear cornea and a good visualization. But what to do if the cornea is opaque because of trauma or damaged severely? Our fourth case here is a 38-year-old one-eyed male who had a severely damaged cornea following a blast injury. His ultrasound showed presence of multiple retained foreign bodies in the vitreous cavity and a ruptured lens with lens matter filling the anterior chamber. We were suspecting stone foreign bodies in this case, which were similar to stone foreign bodies seen embedded on the surface of the cornea. The damaged cornea was refined and removed, and a temporary keratoprosthesis was sutured in place to allow us to visualize the vitreous cavity. We could see ruptured lens matter floating out as the cornea was being refined. After securing the keratoprosthesis in place, first the anterior chamber was cleared of all the residual lens matter and the remnants of the lens capsule were removed. A 23-gauge pars plana vitrectomy was done and stone foreign bodies were seen lying on the surface of the retina. A 3-pronged claw forceps was used to pick these foreign bodies one by one and remove through the ports. The ports were closed, the temporary keratoprosthesis was removed, and the corneal graft was sutured in its place. Our last case here can be a significant challenge for even the most experienced VR surgeons. A 36-year-old male patient presented to us with loss of vision in the left eye following an explosion injury 1 month back. He had undergone a scleral tear repair 1 week back elsewhere. His presenting visual acuity was PL plus PR accurate. The anterior segment showed a repaired scleral tear with pupillary peaking and capilla. There was no view of the fundus. Ultrasound B scan showed presence of a retinal detachment along with a large retained intraocular foreign body. After a 360-degree conjunctival peritomy, a 240 inserting silicone band was secured. The cataractous lens was removed using phacoemulsification. A large wooden foreign body was seen floating in the mid-vitreous cavity. But first we decided to tackle the retinal detachment. It had already started showing signs of early PVR. A 360-degree careful vitrectomy with base dissection was done, and the pre-retinal bands were carefully removed. PFCL was put at the posterior pole, and the SRF was drained through the peripheral breaks. Once the posterior pole was flattened, we decided to remove the foreign body. Since it was a large foreign body, we decided to take out from the anterior root, enlarging the cataract incision.
This is I'm using
Multiple attempts were made to take out the foreign body with the help of 2 forceps using a handshake technique. But unfortunately, we could not find a forceps either having a good enough grip to hold the foreign body or having a large enough mouth to hold it securely and to remove it through the limbal incision. Eventually, we floated the foreign body up using the help of PFCL, and then after enlarging the limbal incision, a wire rectus with indentation was used to slide the foreign body out through the corneal incision. It was almost similar to delivering a hard brown nucleus during an extracapsular cataract extraction. Subsequently, the vitrectomy was completed, the retina was flattened using PFCL, and a 360-degree laser was done. Lastly, a PFCL silicone oil exchange was done. The patient recovered a post-operative best corrective visual acuity of finger counting 1 meter. To conclude, retained intraocular foreign body pose quite a significant surgical challenge by themselves for any VR surgeon. The task becomes even more daunting when these are further complicated by the presence of either vitreous hemorrhage, retinal detachment, endophthalmitis, or a compromised view. The successful management of such cases thus requires an array of different surgical techniques, varied instrumentation, a well-formulated pre-operative plan, and a prompt per-operative adaptability to alter that plan as and when required. Thank you.
Thank you very much.
Retained intraocular foreign body.
Great cases. I think the most important challenge, I think, is like you showed in the last case where you have a corneal incision and it keeps leaking, and the foreign body, it keeps moving inside the globe.
Actually, it was not leaking. The basic problem in the last case was it was such a large foreign body. I used everything. First, I thought I'll bring it with suction to the pupillary area and I'll catch with the McPherson. Because of the round nature of the foreign body, it's used to slip. And the moment you enter with the McPherson, the pressure goes down and it falls down on the retina. I tried 3 or 4 times with soft tip and without soft tip. Didn't happen. Then I used the claw forceps, what you saw in the last case. The claw forceps, the claws were not big enough to catch hold of the intraocular forceps. So I was actually stuck in that case, how to bring out that foreign body. Nothing came in mind. I asked for everything. I couldn't remove the foreign body. Now leaving a foreign body, doing a foreign body case, it becomes a big, if you don't remove it, becomes a big medical legal issue. So what I did is I said I'll float it with PFCL. So lucky for me, it floated over the PFCL, brought it into the pupillary plane, and then removed through the corneal incision.
No, that's a very important point you have made, Dr. Avninder. Ultimately, there will be some foreign bodies where no forceps is going to be able to hold it. Either they are very smooth, like a marble, they're smooth and but big, or sometimes you have a car accident, windshield, the glass is broken and multiple, the cuboidal irregular edge. No forceps can hold it, and even with suction, you won't be able to. It will be so irregular that it will fall back, and that PFs.
And sorry to interrupt. And in multiple fall also creates a break. I created 2 breaks on the temporal side of this retina, but
so PFCL with vectis, as long as one of the axis is long enough to be broad to be a, otherwise through the vectis it can fall if they're small.
Yeah.
But the one like you are, so when you started off with that case, I was thinking this vectis will be the best option in that case. It's like 2 hand. PFCL is one. It'll maybe float up. Even if it doesn't float up, you can do a bimanual and gently place the foreign body over the vectis deep inside the vitreous cavity and lift it. Obviously, through the anterior incision only you can take it out. This big case, but very interesting, very challenging. And one other point, even for the smaller foreign bodies, the simple one which you were talking, the first case, many times we think that the sclerotomy is adequate for the foreign body removal. While the sclerotomy may still be adequate, the choroidal incision choroid doesn't get cut very easily with the MVR. The sclera gets cut more firm, but choroid moves but doesn't get cut. So you have to make sure that the choroidal opening is big enough. Otherwise, the foreign body gets stuck in the choroid. Yeah.
Just to add
Yes, sir.
to the same point that you are mentioning, instead of using the wire vectis, what I have found useful is the old lens spatula. We had in days of yore when we used to do extracapsular and use a lens vectis, a lens spatula, not the vectis. The vectis always seems insecure that the foreign body may again drop. So estimating the size of the foreign body versus the horizontal width of the vectis, wire vectis is a problem. So a lens spatula which is completely flat will be a good alternative. So that's one
the
instrument.
problem, sir, nowadays is they are not giving
don't
old
have
instruments
it.
in the theater.
Yeah,
We only
but
have
lens
vectis.
spatula is there in our armory, so it's
Okay.
good to put it into the
Okay,
IOFB kit.
Just a question for the Dr. Avninder and Dr. Rajan panelists. What to do if you have a foreign body, especially in eyes like endophthalmitis, young eyes, where you're not able to achieve a safe PVD around a foreign body, or you're not able to get a PVD. So how would you approach in that kind of a scenario?
See, my take is at the moment I'll remove all the posterior hyaloid. I'll induce an PVD and remove the foreign body, and after that I'll put a silicone oil in that with antibiotic. So any doubt, I'll put silicone oil.
I think sometimes no matter how hard you try, you cannot induce PVD around the foreign body. So it's so firm, so you try to just trim it, and that's all you can do. I don't think you can remove it in all cases.
Yeah, this problem comes in young patients where PVD induction is difficult. The safety you go with the intention to separate the hyaloid. If can done safely, you go ahead with it. If not, I don't have any problem leaving the hyaloid. Later on, tackle it if there is any issue. But you can leave the sheet of hyaloid if there is no other problem. But if there is a retinal detachment, yes, I'll do all kinds of, you can use forceps to induce PVD, obviously stain them, and use finesse loop. But if it's a retinal detachment, we do everything possible to detach the hyaloid. Okay.
Thank you, sir. So with this, I'd like to invite Dr. Ajay Purohit, who will talk to us about my learnings through SF-IOL surgery.
Good morning, everyone. I would like to thank Dr. Ritesh sir for giving me this opportunity. I would like to discuss my steps of SFIOL, which I do, and the learnings which I've done from SFIOL. And these steps do a stepwise. First, we do the incision making. So incision making for the routine SFIL, I prefer routine SICS incision, which is there. And for me, it's a very comfortable incision. It's give me a good area to maneuver the lens. But in sometimes, this is a routine. Make sure that it's around 5 to 6 mm so that IOL insertion is easier and do not hustle during IOL insertion. So this is a routine SICS tunnel which I usually make. You can see the dislocated lens which is there. And sometimes we need to reopen the SICS tunnel. This patient was operated a week back for a subluxated lens, and anterior vitrectomy was done. Now after 1 week, the patient presented to us and we planned for an SFIO. So I just reopened the previous SICS tunnel. I did not make any new tunnel. You can see that there's some difficulty in opening the tunnel, and because of the fibrosis which is there, but ultimately I was able to open the tunnel, and this made me not to make a new incision. There was a pupil dilation, and this patient, he had already done an SFIL. He presented to us, and there was superior fibrosis which was there. So I planned to go for a clear corneal temporal incision to explant this IOL. So incision is not just only SICS easy incision. You can get these patients also which previously operated cases were there. So you can see the knob is there, which this patient has already undergone 2 secondary IOL surgeries, and he was implanted with a CMT flex IOL, and a small eye, colobumbatous eye, and all throughout almost 270 degrees the fibrosis was there. The cornea was already involved because of the previous surgery. So this time I did make an SICS tunnel, but because of the fibrosis, the tunnel making was not that easy. So we need to counsel the patient. We need to do a good preoperative corneal evaluation also, and corneal decompensation chances are always there. You need to counsel the patient first. So ultimately, you can see the knob of CMT flex which was there. And for infusion system, my preferred practice is going for a pars plana infusion system. But if you're an anterior segment surgeon, you do not not confident for pars plana incision, you can also go for a AC maintainer. So this is how routine pars plana infusion system does work. This is my preferred technique, but for anterior segment surgeon, you can always go for a AC maintenance also. It's always important to maintain the AC during this SFIL thing. My preferred techniques is I use a XNIT and a Yamanase mixed technique, which is a modified XNIT or a modified Yamanase technique. In this, we go for an oblique tunnel around 1.5 mm from the limbus, and we guide the 26 gauge needle through the superior SICS tunnel. This guiding is important. You need to use your forceps to guide, or it will damage the cornea or the root of the iris. And then the leading haptic is rail tracked into the haptic, and the IOL is slightly pushed into it. And just make sure you do not come out very quickly, or the haptic you lose the haptic. And just with the help of the stopper, just pull out the needle, and that's it, the haptic is out. And just make sure you do not pull the complete haptic out. Make sure the part of haptic is out, because it will help to easily maneuver the trailing haptic, or else there won't be any place to maneuver. So when we put the leading haptic, pulling the leading haptic inside, make sure the 26 gauge needle is in extreme of the tunnel. Do not make it sit at the middle of the tunnel, because then maneuvering the haptic will be more difficult, and will end up breaking the haptic or bending the haptic. So just pull the needle to the extreme end of the tunnel, slightly, very gradually catch the haptic, and just rail track into the haptic. Only the 3 to 5 mm of haptic into the 25 gauge, and just pull it out, and that's it. And just the haptic won't go anywhere because it's a oblique tunnel which you have created. Now we can always cauterize the haptic. Cauterizing will make a mushroom shaped terminal at the of the haptic. You can always use a electric cautery or a heat cautery. I've used a heat cautery here because then that day the electric cautery was not working. So heat cautery is also always handy to use. Make sure you don't touch the cornea when you use a cautery. The terminal bulbs need to be flat enough, or it should be like a tabletop, or should be mushroom shaped opening, so it doesn't fall off the 26 gauge track which we have created. You see that bulb, it needs to be, it should not be haphazard, or it will irradiate the conjunctiva and come out post-operative period. Same do with the other haptic also. And just push the haptic, and you see this knob. It needs to be a good knob and a flat knob, not a rigid knob. Just push it subconjunctivally. Sometimes you can also do a localized peritomy, push the haptic and just pull the conjunctival back up and suture or glue it the conjunctiva, so that you are sure that it's going subconjunctival only. Whereas post-operative, you find the haptics going coming out of the conjunctiva, the patient will complain of foreign body sensation. So if you see these things, the results are, these are immediate day 1 post-op periods. This is subluxated lens, this is well centered, which is there. 6-9 vision, first day post-op, corneas are clear. The haptic, the knobs are subconjunctival, there is no exposure of the knobs. This again the coloboma eye which was done, the CMT flex subluxated lens, and then the first day post-op lens is centered, and this is the traumatic lens which was well centered the first day. Thank you.
Thank you, Dr. Ajay. Just like to want to know what is your reason for using this particular technique, for what is your advantages that you find with
so one
this particular
advantage
technique?
which I actually find is that the maneuverability is easy. We are maneuvering the IOL outside the eye. It's not inside the vitreous cavity. Some surgeons, beginning surgeons, can have problems maneuvering the lens which is inside the mid-vitreous cavity or inside the eye. So this time, in this technique, the lens is outside, and we're just maneuvering the lens from outside only. Second, the dissection part reduces. Making flaps for SFIOL, the dissection part actually goes down. The time of surgery actually goes down. If everything goes right, the surgery will take around 20 to 25 minutes, and the post-op days results are fine. The patients are extremely comfortable, and I have almost 2.5 years of follow-up of patients. They're extremely happy. There's no IOL, the haptics are not exposed, no end-off, and patients are extremely good vision.
In the presence of ports, when you're doing vitrectomy, along with which invariably you may be needing in
Yes.
most of these cases, does those port have any kind of do they hamper your movement?
Yes, definitely. These ports do hamper. You need to be very careful. Or sometimes, if when you are about to implant the lens, just remove one of the port, especially the superior temporal port. Just remove the port, implant the IOL, and then reinsert the port and complete your vitrectomy. But this is one thing which is actually there, which the practical problem which actually happens.
Any comments from the audience? Yeah, Divyansh.
Such cases, one of the issues that what we was listening to circle is they can have exposure of the haptics or a part of it which can be exposed. So in those cases, what we have done is utilize the green laser itself. So the green laser cauterizes that edge,
Yeah.
and then it retracts back inside. So we published that also. It is very easy how we do a focal laser. It's a single spot, either 100 microns, spot size power maybe around 100, 200, and duration 20. And it very well retracts into the conjunctiva without doing the surgery.
So when you do that, when you retract, when it retracts, when you cauterize, or when you do these maneuvers, does it affect the tilt? Does it cause
No,
any
sir.
astigmatism, or does it move inside?
Not really, sir. There's no tilt. The IOL keep it stable throughout the day.
In my practice, I usually use 4-point fixation IOLs like Acryos, and I find it to be quite stable once you have the initial. But your initial measurements and alignment has to be very
So
good.
the 1.5 to 1.75 from the limbus is actually important, or it will lead to optic capture.
Right.
The iris will get captured. So the distance
One
will.
of the reasons why the tilt occurs in this case is because if you have not centered or both the alignment of the ends, like the haptics, whichever are at the bulb, if there one is little tilted, also that will
cause.
option reflect on the lens, and that is what in my cases the maximum tilt I have seen because of that is 3 diopters, which patient was okay, so I am still planting.
So I just had one more question over here. So if let us say hypothetically you put an air bubble or something, and then will that cause a tilt? The reason I'm asking is that there are times when we do it along with our consciously. When you want to do a TMM or a DSEN along with a secondary activity. At that point of time, one of the concerns they have with technique is that when they put an air bubble after the DSEN, the IOD will not be done. So make experience with that.
I could have done PKs also, open skies, but in those cases, if I have wrongly calculated
so it's controlled.
Go back to the same way. So it doesn't.
I think better to avoid.
Better to avoid that, but otherwise put the visco and add it into some time and then.
But with the DSEC, we can't put visco. The air needs to be there. But it's just a temporary tilt, sir. It's just a temporary tilt. I've
Exactly
been 2 cases, just a temporary tilt. And the time air absorbs, I will again.
So I've also done it, but every time when I do it, I live with a small fear that this
No,
may
no,
happen.
no.
That's why I'm asking anybody has got more experience.
No, so I don't do SF files. I stopped long ago. But even if externally you think that you are perfectly aligned, 180 degree apart, equal distance, sometimes the problem is inside when there's part capsule, part vitreous, one side, and that won't. Even if from outside everything is aligned, inside everything is one will be. There's no space for the IOL to be in the correct centration position, and if you don't tackle that, whatever you do, you may end up with problems. So that is something very crucial, even for SFIL surgeons who are that you must do the anterior segment reconstruction properly. Make sure that there is space for the IOL to be equally aligned on this.
This is a very good technique. The thing is, I've done once only. After I did it, unfortunately, the lens got decent. But the
Subluxated. You got subluxated or
decent. But the one happening was promoted next year is the other one.
Yeah, it can bend the haptic, and sometimes it can slide back a little. It can move a little. So that risk is.
Make the double exactly at the same place.
Yes, sir. That is the thing. And even if when you are contrasting the haptics, you need to be careful that you contrast almost the same thing. When contrast one more and one less, it will go like this. And the post-op period, you will find a haptic popping out of the control.
So what Dr. Mudit was saying, and what coming out of discussion also, was the reason exactly why I have never really been a big fan of this technique. Like a sutured SFIOL, this has only a 2-point fixation kind of it's hanging on that cautery edge, or earlier we used to hang it on the suture. Vis-a-vis when you tunnel and tuck that IOL, a length of it inside, it becomes a little more stable
we
into
can
the
do like
sclera.
this also. Only there you can use the needles to externalize the haptics. You can make a tunnel, tuck it in, and
So when you have a little broader length into the sclera, it gives it a little more stability. And in that cases, even with DSEC eyes,
it will be more stable.
it is more stable. It doesn't turn with. And what Dr. Aryan was saying, I have actually cancelled quite a few SFIL after doing vitrectomy and examining the ciliary body area, and I have found either from a previous VR surgery, some anterior segment PVR, neovascularization, or an unhealthy ciliary area where I know implanting an SFIL actually may be a more harmful thing, and I've actually not done it. On table also taken that call and not done it.
That's very, very crucial, that if you don't have enough space over there, you will have the IOL one part coming out and decentered.
Or it may bleed during surgery, post-operatively, so all those
And
things.
sometimes
One more point to add to that will also be conjunctival fibrosis. So before planning for an SFIL or a blue line, it also becomes important to assess the condition of the conjunctiva. The patient is already undergone multiple surgery. Sometimes you may find the entire conjunctiva fibrosis, and there is no place for you to maneuver. So you either need to make a placement or entry in an alignment which is away from the liver fibrosis, or probably not do a second IOL.
sometimes we are lucky that actually if we are open mind, instead of just saying I'm going to do what I have planned earlier, but you go and see there is sometimes substantial capsular support already there. You can put it as a 3-piece IOL right in the sulcus itself and not struggle with the other. Yeah. If the iris is there, there are so many other options. Iris fixated IOLs are also there.
Okay, thank you so much.
Thank you,
So
sir.
with this, I'd like to invite my friend Dr. Mudit Tyagi, who will be talking about viral retinitis related retinal detachments.
All right. So good morning, everyone, and a big thanks to AIOC and the chairperson and the session moderators for giving me a chance to talk on this. So I will be talking about detachments post viral retinitis, so either a CMV retinitis or acute retinal necrosis. And what we need to do is that RD is often complicated by proliferative retinopathy, can occur in 40 to 60% of patients with ARN. Same holds true for CMV retinitis, the RD rate of 8.7 per 100 IES in one of the papers was described to the incidence of retinal detachments in patients post a healed CMV retinitis. And the thing is that these eyes have got both a tractional as well as a rhegmatogenous component, and surgeries in these cases can be slightly more challenging, can have some more different aspects as compared to what we will otherwise do in our conventional simple rhegmatogenous retinal detachments. So what are the problems that we face? First is a pre-existing retinitis. Now if you already have an active retinitis, that sometimes can be a bit of a tricky challenge. Most of the times detachments in these eyes occur once the retinitis has healed and you've got peripheral areas of necrosis, so that is the area from which new breaks occur. But sometimes if you have an active retinitis, you also need to take care of that, because causing a vitreous traction over there pulling may lead to much more breaks. So either you can resort to giving an intravitreal ganciclovir initially, starting them on treatment, wait for few days for the retinitis to resolve, and then go ahead with the surgery, or at least give an intravitreal ganciclovir at least 3 to 4 days prior to the operation. But luckily that is a rare occurrence. Most of the times the detachments in these eyes will occur once the retinitis has healed. The other thing is abnormal vitreous additions. These eyes have got vitreous which is slightly different from what you would otherwise expect. These eyes have got an inflammation earlier, so the vitreous is more thickened and there are abnormal additions in these eyes. So let me just show you what I meant by that over here. So if you look at it, you can see this thick sheet. That this thick sheet is actually the vitreous which we are cutting over here. And these eyes have got extensive peripheral vitreous adhesions. If you can see these sieve-like attachments over here, and this changes over. So vitreous is thickly adherent to the periphery. Sometimes you have to be careful. If you're trying to pull over this, you will create much more breaks over here. The best option in some of these eyes is then just to go ahead and truncate and shave and remove as much of vitreous as possible. So if you look over here, this is what we're trying to do. We try to remove as much of peripheral vitreous as possible with the help of your cutter, and at the same time be cautious of the amount of traction that you are exercising over there, because if you pull too much, you will create much more breaks in an area of retina which is already necrotic and thinned out. The other point apart from that is a necrotic retina which you see in these eyes. So this is what happens, that this is the reason why you get breaks in these eyes so often. The fact is that you've got an entire peripheral retina which is thin, necrotic, what we call a sieve-like retina. If you look carefully over here, in these areas you'll observe these multiple small breaks in the area of retinitis, in the area which has healed earlier. So these are the kind of multiple small breaks that you see in this area, and you have to be careful, again like I said, to remove the vitreous over here, truncate it. Sometimes you may just excise and remove this area of retina, but most of the times you don't need to do that, because once you have flattened the retina, a lot of adhesions and fibrosis anyways occurs over here. So you may not have to do a retinectomy all those times, but you need to observe this configuration and see that this is the reason why detachments occur in these eyes in the first place. One more problem is the thick membranes, or the epiretinal membranes which occur in these eyes, and you have to be careful in removing them meticulously, because one of the most common causes of recurrences in eyes which have had a detachment post ARN or CMV is the fact that we sometimes end up leaving these membranes behind, and then you have got a kind of a shallow detachment which occurs again with, you have got a very minimal, these will not be very bullous sort of configurations, but you will always have that persisting fluid till the time you take care of these membranes completely. So this is what I meant over here if you look at it. So these are membranes. Again, be careful in removing them, but remove them meticulously. If you want, you can even stain them with brilliant blue to assess what are the underlying membranes which have been left behind. But lift them up carefully, remove them. You can even use a scissor or a forceps at that point of time to remove all of these membranes carefully, because till the time you remove them, the pathology will not be rectified and you will end up having recurrences. So in this case, we were truncating some of these membranes with the help of a forceps. Remove as much of it as you possibly can. And let me just show you what else can happen over here. So this was another patient over here with this thick membrane which was adherent. And once you start lifting it, again, you will see that we ended up actually creating one break, much to our dismay, but then thankfully we could drain the fluid from that area and settle the retina subsequently. So this is how membrane removal goes in these eyes. Just remove them carefully. This was one break which happened over here. But after you remove most of these membranes, the retina does become bullous, freely mobile. And then the steps are simple. You just need to go do a fluid exchange. The other point about this case is the fact that when you do a laser, you have to be careful and cognizant of the fact that you need to do laser in the area of the healthy retina. Most of the times I end up doing a 360 laser, demarcating the areas of healthy retina away from the unhealthy or necrotic retina, so as to ensure that that stays over there. In terms of oil, so this patient before this is how the patient responded. You can see the flat retina, visual acuity also improved subsequently. Now the other point or the conundrum which a lot of times people face is the kind of tamponade which you need to put. Either you need to put 1,000 or a 5,000 centistroke oil. In cases where you have got an extensive peripheral necrotic changes involving more than 2 to 3 quarters, we end up putting a long-standing tamponade or 5,000 centistroke oil. But in some of these cases where you just got a localized area of detachment, we have actually just put 1,000 and even gone ahead and done an SOR, and those patients are doing fine. But in most of these cases, they will end up needing a long-term tamponade. And I do not know why, but surprisingly, the amount of emulsification which we see in these eyes is surprising much lesser than what you will see otherwise in a reg RD. So we have had patients who have been having the silicone oil for 4, 5, 6 years altogether with no emulsification, and I don't know the reason for that. But luckily for us, these eyes show a significantly less amount of emulsification to 5,000 centistroke oil as compared to what you would otherwise expect. So in summation, these are the kind of challenges and the points which you need to tackle and take care of when you take care of detachments in eyes post retinitis. So they offer a different set of challenges, and vitrectomy is preferred over buckling because you need to take care of all of those peripheral membranes, and vitreous adhesions, necrotic retina and thick ERMs need to be addressed. Thank you so much.
Yeah, nice video, Smudit. In terms of the emulsification which you were mentioning being less, I'm not sure if you compared, non-viral retinitis kind of patients and found, well, normally we use 1,000 centistroke oil in the other cases, and that tends to emulsify. But 5,000 oil, I feel, even for other cases, it stays very long without any emulsification. But going back to one of the other points is there are so many multiple breaks that you see in these eyes.
Yeah.
See, like in regular RDs, we usually tend to identify each and every break and laser them. But what is your approach in these cases? Do you consider that entire necrotic area, even if there are multiple, as one lesion and you have to laser around it, or you try to identify each and every break?
So if, like I said, if there are breaks in multiple quarters, multiple of those breaks, then you usually treat them as just one continuous area of breaks over there. And the other thing is that once you have settled the retina, a lot of times in these eyes, there are people who prefer doing a retinectomy and removing that entire area of retina over there. But you don't need to do it in most cases. There is a fibrosis which occurs over there. So you don't have to do that, but you do end up treating them as one single contiguous sort of a lesion. And I do end up doing a 360 laser in most of these cases. And as far as the emulsification is concerned, I know that we have not actually compared between conventional RDs and post-retinitis RDs. But anecdotally, what I have seen, and maybe Dr. Vishali ma'am is here, and you people also deal with a lot of AR and RDs. Maybe ma'am can share her experience of that. We do see somehow less emulsification in these eyes, and for reasons which, to be honest, are hitherto unknown. So.
There are 3 points I would like to add. Whenever you do vitrectomy for these, even though it is therapeutic, you always take out the initial sample and send it to your lab. That should be done just to confirm and see how we are with the cytokines and other. The second, as you said very rightly, there is no point putting a diathermy like Raja was asking to identify each and every wound, because the diathermy itself is going to cause a lot of damage. So you just treat the entire seam like retina as a whole, border edge and all. Thirdly, many times when you were removing the membrane, when you go mid-periphery, that is the area where it is very adherent and difficult to remove. So sometimes if you need to support it with the broad-based buccal, that is always better than doing retinectomy, because large retinectomy in these eyes, when you do a long-term follow-up, it really doesn't work. So you can leave that traction up to mid-periphery and support it with the buccal. And lastly, I have the same experience. Silicone oil does not emulsify. And in very rare circumstances, when it has been a bad detachment, you can always plan a silicone oil exchange rather than removing the silicone oil, ending up with detachment again and going back again.
Yeah, that's what we have done in some of those cases.
Absolutely.
In those rare ones, you just remove it and put a new.
Yeah, you just plan electively to do a silicone oil exchange.
Dr. Vishali, this is coming from the fact that, as you were showing, there's a lot of vitreous which is which you may not be able to detach from the retina. Your PVD will not go as far anterior. So there will be always a higher chances of developing anterior PVR, loop PVR. Now with that, you're not seeing emulsification. Are we dealing in most of these eyes with some amount of ciliary body shutdown, ciliary body not working, detachment because aqueous is not getting produced? That's why probably emulsification doesn't happen as
No,
much
that's
more.
a very nice probable thought to the probable explanation as to why it doesn't happen. But you're right, ciliary body shutdown, ciliary body hypoperfusion, atrophy, all of those anyways do occur. These are sequelae of long-standing uveitis. Those membranes also. So a lot of times you will end up having this eye with an attached retina, but still continuing with some amount of persisting hypotony. The IOPs may be ranging from 6 to 8 to 9. And probably that can be actual logical explanation as to why we don't see emulsification that much.
And also,
Interesting
we
thought.
hardly see glaucoma in these.
Yes, exactly.
Even with this silicone oil, we don't. Rather than 6 to 8, silicone oil in situ. Patient seeing 660, 636. That's a typical scenario.
I think almost all of these eyes have some ciliary body.
Yeah.
Yeah. So that might be a good thought. That maybe that is what preventing emulsification. Good thought.
Yeah. Thank you.
Another point I would like to ask is, we got associated to the hospital, we are beginning of the year. And last year, we got and some of these retina were better than what we find in here. And
CMV retina is very good actually.
Yeah. Much better
Yes,
than ARM.
much
Yeah.
better. It's a quadrantic. You have small little hole at the site of this. They do very well. ARN is a different ball
Yeah,
game
totally
altogether.
different.
Yeah.
this kind of membranes, I've never seen in CMV.
No. CMV is very.
It's a
good.
much better retinal detachment
Yeah.
to deal with as compared to
That's
ARM.
mostly posterior, not much of interior PVR, not much of adherence. Vitreous is clean, so that's very different. Yeah.
Thank you so much. Thank
Yeah.
you. So with this, I'd like to invite Dr. Divyansh Mishra, who will talk to us about common errors in diabetic vitrectomy.
HTML. Connect हो गया.
And send it to your lab. Like,
Yeah.
that should be done just to confirm and see how we are with these cytokines and other. The second, as you said very rightly, there is no point putting a diathermy like Raja was asking to identify each and every rule, because the diathermy itself is going to cause a lot of damage. So you just treat the entire seam like retina as a whole, border edge and all.
Thirdly, many a times when you were removing the membrane, when you go mid-periphery, that is the area where it is very adherent and difficult to remove. So sometimes if you need to support it with the broad-based buccal, that is always better than doing retinectomy, because large retinectomy in these eyes, when you do a long-term follow-up, it really doesn't work.
Yeah.
So you can leave that traction up to mid-periphery and support it with the buccal. And lastly, I have the same experience. Silicone oil does not emulsify. And in very rare circumstances, when it has been a bad detachment, you can always plan a silicone oil exchange
Yes.
rather than removing the silicone oil, ending up with detachment again, and going back again.
Yeah, that's what we have done in some of those cases. In those
Absolutely.
rare ones, you just remove it and put a new.
Yeah, you just
Yeah.
plan electively to do a silicone oil exchange.
Dr. Mudit, Dr. Vishali, this is coming from the fact that, as you were showing, there's a lot of vitreous which you may not be able to detach from the retina. Your PVD will not go as far anterior. So there will be always a higher chances of developing anterior PVR, loop PVR. Now with that, you're not seeing emulsification. Are we dealing in most of these eyes with some amount of ciliary body shutdown, ciliary body not working, detachment because aqueous is not getting produced? That's why probably emulsification doesn't happen as
No,
much
that's
more.
a very nice probable thought to the probable explanation as to why it doesn't happen. But you're right, ciliary body shutdown, ciliary body hypoperfusion, atrophy, all of those anyways do occur. These are sequelae of long-standing uveitis. Those membranes also. So a lot of times you will end up having this eye with an attached retina, but still continuing with some amount of persisting hypotony. The IOPs may be ranging from 6 to 8 to 9. And probably that can be an actual logical explanation as to why we don't see emulsification that much.
And also,
Interesting
we
thought.
hardly see glaucoma in these.
Yes, exactly.
Even with this silicone oil, we don't. Rather than 6 to 8, silicone oil in situ. Patient seeing 660, 636. That's a typical scenario.
I think almost all of these eyes have some ciliary body.
Yeah.
Yeah. So that might be a good thought. That maybe that is what preventing emulsification. Good thought.
Yeah. Thank you.
Another point I would like to ask is we got assistant to the hospital, we are beginning of the year. And last year, we and some of these retina were better than what we find in here.
CMV retina is very good actually.
Yeah, much better
Yes,
than ARM.
much
Yeah.
better. It's a quadrantic. You have small little hole at the site of this. They do very well. ARN is a different ball
Yeah,
game
totally
altogether.
different.
Yeah.
This kind of membranes, I've never seen in CMV.
No. CMV is very.
It's a
good.
much better retinal detachment
Yeah.
to deal with as compared to
That's
ARM.
mostly posterior, not much of interior PVR, not much of adherence. Vitreous is clean, so that's very different. Yeah.
Thank you so much. Thank you. So with this, I'd like to invite Dr. Divyansh Mishra, who will talk to us about common errors in diabetic vitrectomy.
HTML. Connect over here.
Thank you, Anirudh, and thank you, Ritesh, sir, for making me part of this IC. So my topic is fairly common. Most of us would be dealing with diabetic vitrectomies, and my topic is to manage or common errors. So I would show what errors it makes and what it makes to avoid those errors. So like in this case, as what we can see, that when we make a board, sometimes we see that there are bleeds in the anterior chamber. So my questions to the panelists would be how to avoid this, or how to not have this kind of bleeds, and what would be the cause for this bleed?
You mean bleed in intravitreal?
Bleed in the anterior chamber, yeah. So like when I'm making a port, as you can see, there is a bleed in the anterior chamber, and then I have to take the port out and then again try to do. So what can be the reason in this case?
No, there is obviously either from the sclerotomy side there is some proliferation already anterior hyaloid, that can be one reason, and these are difficult to anticipate unless you have, if there is vitreous hemorrhage, you can't see the fundus, you can't make out, and these are, as the situation evolves, we'll have to handle that. But if it's sometimes resurgeries
Then-
where we have there, we are aware of this situation. Apart from the anticoagulant, patients may be on those antiplatelets, and apart from that, if there are areas where you can see actually that this area is quite anterior traction is there, you avoid those areas. That can be made out if you can see the periphery.
So in this
And also in resurgeries, not for you, for the youngsters, avoid the site of the previous port.
Previous
Just go
ports.
away from it, because
little bit.
that is the site which
where
is
there can be
going to have a
proliferation.
problem.
Yeah. So in this case, what I thought was I was very anterior, and I had gone through the ciliary body, and whatever the heme was there was actually occurring in the pars plicator, and that was coming from the root of the iris into the anterior chamber. That's what my thought process. Yeah, but the other points are also very correct if the case is.
Divyansh, one
Sure.
small point. Unpicked up or silent NVAs, the sudden
also-
decompression.
yes,
can
sudden
cause
decompression, yeah.
hyphema into the
Yeah.
anterior chamber.
Yeah, so that also you can make out. In this case, it was coming from behind, kind of thing,
Yes.
and there it will come.
From over the iris and then going behind, yeah. So what would be the take of panelists on cases like this where you have done a phaco and luckily the surgeon has done a superior temporal, and if it's a temporal phaco, how would you want to make ports in this case? Because port is the first and foremost important thing in cases of diabetic vitrectomy, where if the alignment is not correct, your achievement of vitrectomy in superior-nasal, superior-temporal may not be as good. So what would be the take on the panelist first?
Suture, even
Suture.
the side ports.
Even the side ports, that's true.
That really helps. And most of these are small gauge. So instead of making a bevel, just go straight,
Direct stab entry.
direct entry with 27G.
That's
and once you have one infusion in place, the other ports you
Other
can
ports
make
can
by
still be-
raising the infusion pressure.
So any preferences of the surgeon doing a superior versus superior, temporal versus temporal? Any preferences?
Yeah, for me, astigmatism is not an issue in diabetic vitrectomy.
That's true.
If I get to CF 2 meters or 6/60, but I do
Hopefully
my
no
own
cataract
because
surgery.
it's always superior, and I don't have any issue. And obviously, suturing the main port is always recommended if there is any doubt. But overall, I would prefer a superior.
That's true.
I do vitrectomies with 2 cataract surgeons, and one cataract surgeon prefers that I actually make the ports before I start the cataract surgery.
Okay.
And I don't switch on the infusion. I connect
just keep it.
everything, and then he does the cataract surgery.
Mhm. I'm not sure our cataract surgeons would be comfortable because they want to finish their case and then go away and then
Yeah,
leave us with
but
whatever is there.
If you do a pre-fixated infusion, in the sense the cataract surgeon doing a temporal incision may find it difficult again, with that blocking.
So this case assessment, if in my what I'm presenting is because these are the errors which I've done in my early life and I've learned from it. So this was the case which I saw the OCT and I decided, okay, there is some traction temporal to the fovea. It is causing a TRD which is just encroaching onto the fovea, and there is a TRD which is involving the papillomacular bundle. And I needed to assess because it was looking like, yes, the PVD has already occurred and it would be a very nice case for me because there is no PVD and the attachment is very gross. So whether I should just go on this or whether my plan should be according to this to avoid further errors, or I should do something else also. So what would be the take of panelist on that?
In terms of how to go about
Plan this.
Why do surgery?
So no, surgery has to be planned, but whether means in my case, because I want, if the PVD is there, it's a simple case for me. If the no PVD, because already there would be, as you can see, the PVD attachment is already at the edges of wherever the attachment of the vitreous is. So like this.
That's why I'm asking, what was the vision of this patient at this
I
point?
do not remember, but it is in between 612 to 6, not 66 and 69. So in. Why, sir?
The fovea is looking weird.
The fovea is lot of time. I know this can progress, and I don't deny that there probably may come a time when you will need to do a surgery. But if you see this patient for the first time, if I see this today, probably what I'll do is I'll just observe this patient, probably reassess them after a month or 2 months and see if the traction is progressing.
Traction is worsening,
if that is progressing, that's a time for you to do a surgery. If it stays stable, because there will be patients where it will stay like this for ages altogether. And then
So
you don't need to intervene.
This is the hard way I learned.
Because Divyansh, the first thing is indication for surgery when it is
Patient,
involving art threatening the fovea. In your case, fovea is not involved and not imminently threatened. So like Mudit said, we will
Close
just
follow-up.
observe, wait, and many times they would just go on for years.
Having the same vision.
And surgery, all said and done, can cause problems.
So while these are the contraindications or relative contraindications, there still can be an indication for surgery in this kind of situation because of a vitreopapillary traction, vision going on. You document that. And obviously the patient has not been lasered earlier, and you have to do PRP and see if that stabilizes. But if still it is increasing and your vision is going down, it's an indication. But when you say PVD is there or there's no PVD in this.
Just the posterior hyaloid separation.
Posterior hyaloid separation. That too, when you go and actually do these cases with triamcinolone, invariably there is vitreoskisis. There will be another membrane. I don't know if you are showing the video here, but invariably there will be a layer on top of the.
So as what the panelists are suggesting, these cases are not easy and it has to be dealt with utmost caution. And yes, the OCT which is giving you a pseudo appearance that the PVD is there, but actually it's an IPVD and the PVD is already there only on the posterior pole. And cases in which we are able to see the periphery very well, those are the cases which would be having more difficulty at the time of surgery. So this fortunately and unfortunately I took up for the surgery, and as we can see the vitreous attachment is grossly on the posterior pole. So the discussion at this point was whether I have already jumped into the surgery, which we were discussing whether to do, not do. I was an aggressive surgeon before, and then after a lot of mistakes, I have learned that
You are growing up.
growing old. Yeah. So,
Growing up.
with a lot of gray matter and the gray hairs involving. So whether to go from outside in or inside out, I think we would not have operated for surgery. So we go to the full part of the surgery where I had done the surgery and then managed how well. So I could see there was some detachment on the nasal side. As you can see, the attachment is only in the peripapillary area, and anterior to it there is no PVD at all. So all that I am trying to truncate and then induce the PVD further. But in this cases, because at that point of time, again, I was an aggressive surgeon. Okay, I didn't thought of giving an anti-VEGF before the surgery, and as we can see, most of the time the surgical view is occluded by hemorrhages. When I thought, okay, I should just cauterize whatever is important. So as minimal as cautery and as better it can be. So what would be the take of panelists in this case, whether it is bleeding, when to cauterize and how to cauterize? Using how much cautery is enough and how much is more?
Minimal cautery and then lower the pressure. Like if you are doing cautery at 30, which is normal for most of us, lower it to 15 or 10 and see if that point is oozing. If that is not oozing, there is no need to apply more cautery.
More cautery, that's true. Any more comments, sir?
Yeah, this kind of case where the most of the fibrosis and contraction is over the disc. Usually what happens, we see a lot of arcade contraction, tabletop. There I think about inside out or outside in, but where there is vitreopapillary, mainly on the disc, just go there. Obviously you do the rest of the vitrectomy first, just the hyaloid is remaining. Disc is the best area in terms of, although people talk about bleeding, but as long as it's avascular, you just lift it from there gently and the remaining
trim it around him.
Hyaloid. So it just comes as a nice, in this particular, it can't be done in any other cases, this particular.
It does come, and generally you find a very nice plane between the disc and the temporal.
Yes.
There is always a hyaloid bit lifted there, which you can gently truncate and find the plane to disc.
And
I
the
totally
disc is the
agree.
best area where you avoid break, because you can't create a break over the disc.
That's true. So Ritesh, do we have time?
So I absolutely agree with what RN and Dr. RN and Dr. Vishali are saying. Just assess our disc, and momentarily for that step, I just take the bottle height to like AIOC2023.
Little high to control
pull it, just gently lift it and leave it, and then you can just, and I don't try to be too aggressive nasally. Once I have my macula and temporal done, nasal,
just trim
I'm
it and
not
leave it. Yeah.
too concerned about it.
So Dr. Ritesh, shall we continue? It's 10. So okay, so this case, as what the continuation, what we can see as being an aggressive surgeon, I am seeing the patient again the second time in the OT of developing a detachment, and this is the PFCL which I have put and tried to identify if there is any
Not
SRF.
visible probably. It's not visible.
I think यहाँ उधर इधर दिख रहा है, but वहाँ नहीं दिख रहा है.
Can you switch off this?
Nothing can be switched off. Yeah.
It's a single light.
That's how a
So
diabetic patient
this
will
was a
feel.
case where the same case continuation from the OCT. I did the fantastic surgery. Then the patient landed up into an RD, and then so the problem was I thought the retinal detachment has occurred because of the cautery which I have done. So that's why my question was that whether I had created a break of over enthusiastically cauterizing the bleeders, because what I could see that small area where I had cauterized before, that's the area where the detachment or the break was. And the posterior pole was only detached, the periphery was attached. And so the question is, what could be the cause of break? Yes, obviously we couldn't see the video right now.
See, aggressive cautery, especially when you still need to tackle membranes around it. The cautery will make that retina
Contract.
and then you're doing a lot of dissection around it. The break will keep enlarging. So as Dr. Vishali was saying, avoid cautery or minimal cautery, especially in the areas where still membrane dissection needs to be done. So we can probably would have avoided it. I mean,
The thing is, any time you do a cauterization, you have to treat it as a break.
break and then laser it around. Yeah. So this was the learning which I got from this, that I
But
was
low laser. Sometimes laser itself can cause
breaks.
So that's
not-
a very important point. So
Very
we
true.
all say, okay, we do cautery laser around the cut, but it's an elevated retina, there is hemorrhage, and you do the laser, you won't realize that you have created a. You think that it's whitening, but sometimes you see a smoke coming out
Yeah.
or a pop.
Pop up.
Pop,
coming.
yeah.
That means you have created a break, and if you don't tackle that, that means you have to keep on enlarging the area of laser. But if that is not assessed immediately and you don't take action on top, so if there is an elevation, don't try to laser on top of the elevation. If there is hemorrhage, that's why we say earlier focal lasers, don't do in the area of retinal hemorrhage, don't do laser, because the hemorrhage will absorb the laser energy and create a break.
That's true.
So one way to get around this is, instead of short duration, normally if you're using endo laser 120, 150 and duration of 100 milliseconds, instead of keep on increasing the power to getting, if you don't get the laser burns, increase the duration. Long duration laser is safer versus a high power short duration. Short duration high power will create a break. Long duration low power is just a small, it's like cooking on a slow flame. So that's what
You can use that instead of cautery also.
Yeah, that is also one.
That's what
yeah.
Steve saying that
does
don't
that,
use
yeah.
cautery, I use laser, and we all end up saying I never get diathermal or
Laser induced, yeah.
laser induced. I can't, hemostasis is not achieved, but probably he's not able to say or what. I think it's long duration and low power is
Low
what
power.
you need.
Ritesh, shall I continue or because
We'll have to wrap up.
Sure.
Dr.
Thank you.
As you're shifting one more point, Sunday I remembered, when a lot of people I see, when especially with fellows, when they're trying to trim their membranes, they try and go too flush to the retina. It's better to just leave a little bit of membrane off so that you can diathermize the membrane and not the retina actually. Okay, and invite Dr. Rajiv Jain. He is going to be talking about his lessons learned through endophthalmitis. And Dr. Rajiv is a VR surgeon from Delhi, and he has his own good prolific practice there. Dr. Rajiv.
Are we good to go? Hi. Good morning, everyone. Thanks, Ritesh, for having me here. So, management of endophthalmitis revolves around good medical management as well as surgical intervention, and the primary aim being salvaging the eye as well as a good vision. So, the first insights were provided by endophthalmitis vitrectomy study, where they had concluded that early vitrectomy is useful only when the vision is light perception or less. And if the vision was hand movements are better, whether you go in early or late, it doesn't matter. But we must realize that this study was done in 1980s and 90s, when our surgical instrumentation was not that great, and there was various pitfalls. Nowadays, our management of endophthalmitis is determined not just by vision, but the clinical picture and the course and the severity of the disease. We normally go in for injections if we can see the retinal details. If the red glow is very good, then we go in for injections. But if there's a lot of exudates, the glow is very poor, or we can't see retina, we go in for early vitrectomy. So there's various studies done in Europe and US. CVS study is one which have shown great results post early vitrectomy in endophthalmitis. And as I said, there are various conditions where you want to go in early, like where the infection is very severe, you cannot see any retina, there's a lot of exudation in the retina, and bleb-associated endophthalmitis, suspected fungal or endophthalmitis with the intraocular foreign bodies. So all of us know why vitrectomy. Vitrectomy helps us get the vitreous samples in adequate quantity so that we can grow and culture and be specific with the antibiotics which we give. It clears the ocular media so that we can assess the retina. And we have better diffusion and penetration of various antibiotics which we put inside the eye. And besides that, all the toxins, endotoxins released by bacteria and other organisms get cleared off very quickly. So I think I'll go by video, and most of these cases they have membranes and hypopyon. it's always better to clear this membrane after securing the infusion cannula. And as in any other vitrectomy, it's at most to see the infusion cannula inside the vitreous cavity before going in, before starting the infusion cannula. And this is how we do it. If you can't see it in a handshake technique, go clear the exudates over the infusion cannula till you see it. You keep on cutting, and this is a high cut, very low suction. Once you see that shine, that means you are inside. Your infusion cannula is inside and you are safe. And this bubble, when it comes, it tells me that you are actually in the vitreous cavity. So once this is done, you can go on with your regular vitrectomy. Whether you go in for complete vitrectomy or core vitrectomy, that you can decide on the severity of the infection and other factors, which we'll discuss. So I don't hesitate to scrape epithelium, because a lot of cases, infected cases, people say don't scrape the epithelium, you'll have a corneal infection also. The thing is, if you can't see retina, you can't see vitreous cavity, your surgery is of no use anyways. So clearing the ocular media is of utmost importance, as we discussed earlier. And the way we take vitreous biopsy sample, earlier I used to start the infusion as soon as I start taking the vitreous biopsy. Nowadays, what I do is I attach syringe to the aspiration tube, and we cut. I'll just show the video there. You need undiluted sample. So this is dot cutter, and there's a connector in the aspiration tube. So this connector, you put a syringe on it, and once you are inside, you just cut, don't aspirate with high cut rate. And once you've started cutting, after a few seconds, you aspirate with the syringe slowly, so that you don't put a lot of traction on the vitreous and don't pull off the peripheral vitreous. The cutter is working, and my assistant is aspirating it slowly with the syringe. And then when you take it out, you can just bring the whole thing out and send the sample for the cultures. And as we see, these vitrectomies are from top to the bottom. You start from the IOL and then you go down, because you want to see, as you go down, you want to see the ocular structures. And I normally, the norm was core vitrectomy, where you go in, you create some space so that you just push the antibiotics whether you see anything or not. This is what the classical teaching was. But nowadays, we keep on doing the vitrectomy till we think it is safe. Whether to induce the PVD or not, that is very controversial. If you don't see any necrotic retina, you don't see any bleeders in the retina, PVD can be induced. But most of us, we leave attached vitreous behind if the PVD is already not there. And inducing PVD, because most of these cases they get ERMs later on anyways, so you have to go in most of the times again. So we don't push too much for PVD induction. We just clear the vitreous cavity, clear as much as vitreous possible, especially in the center. Don't go much towards the periphery in the fear of creating inadvertent breaks. And another question is whether to explant the IOL or not. Most of the cases want to preserve the intraocular lenses, and except for fungal endophthalmitis and P. acnes endophthalmitis, the advantage of removing the IOL is that you get a single cavity. You can inject and the antibiotics, they diffused into the anterior chamber as well as posterior chamber equally. And this is mostly in severe cases, and especially with fungal and P. acnes endophthalmitis. Traditionally, we were taught not to put silicone oil, but it is not necessary in all the cases. But wherever you find breaks or suspected breaks in the retina, that is the time we push silicone oil. The only important thing you have to realize is you should have, if possible, done a PVD. Although I've seen cases where we have put oil without inducing the PVD also, because later on you can tackle with the retina. But yes, if it's better to do the PVD and put the oil. The oil has another advantage that it is bacteriostatic, so it helps in slowing down the growth of microorganisms. And the caution is you have to reduce the dose of the antibiotics which you are pushing inside the eye. Thanks for your kind attention. Thanks.
Thank you, Dr. Rajiv. That was quite a comprehensive discussion on end of vitrectomy. We have comments, so I think time for 1 or 2 comments, Dr. Rajan.
Nice videos with extensive vitrectomy. As you mentioned, I agree. We need to be very cautious in peripheral vitrectomy. Although we are doing more vitrectomy than what we were doing earlier, including hyaloid separation from the retina. But periphery, you need to be careful, because if you create a break, then it's like almost losing that eye. So the idea is not to remove the entire vitreous and like any other VR surgery. But yeah, as long as you can do a safe vitrectomy, more than just a simple core vitrectomy, which is possible nowadays, we go ahead and do. Yeah.
One additional point, when you were doing that anterior chamber manipulation to take out that membrane and putting your infusion cannula, rightly said that we need to visualize the tip of the cannula before we are switching it on. I very often start off with an AC maintainer or an infusion in the anterior chamber, and till a certain amount of my actually anterior vitrectomy is also done, and beyond that only I try and then shift to a posterior infusion. I generally don't even try and put it before that, so that's one difference which I generally do that.
I have a question. Do you have access to a 6 mm cannula now?
Yes, we have that old sutured cannula is there, but then with these 23 and 25 gauge, the cannulas are already too long.
No, but they stopped manufacturing 6 mm, at least Alcon. It's not available in the market, so I just want.
No, we have it. I can give you one. If you want.
Sure, desperate for one.
Only I want to ask Nayan, do you still follow that Venco Kefta, or you've switched to Venco
Imipinum? We switched to Imipinum long time ago, but our recent data shows that in the endophthalmitis management study, or EMS, almost 60% of the GNB are, I would say it's only 60% sensitivity to Imipinum also. Forget about Cefta. When Cefta came down 60%, that means 40% resistant. Now Imipinum also, it's only 60% sensitivity, whereas colistin is about 98% sensitivity is there. So we are giving Imipinum, but at least in Vizag, Avinash is more in favor of colistin in the first instance itself.
So Venco plus colistin, or Venco plus Imipinum?
Imipinum, or at least colistin, but not Ceftavis. Yeah.
Okay. Because the message is still, a lot of people still struggling with finding the right antibiotic for gram-negative bacilli, because these are the ones, if you get Pseudomonas.
Yeah, so ultimately it's from your own profile that you also have to look at, but our data, our organisms are quite resistant to Imipinum.
Also, you have to look at the antibiotic susceptibility patterns. They keep on evolving over
Yes.
time. Earlier we had Cefta, then Imipinum, now colistin. Sometimes you can also make a decision on the basis of a clinical judgment as to the presentation. If there is extensive corneal melting, ring infiltrate,
Yes.
scleral melting is already started, makes sense for you to go with Venco plus Imipinum. Because probably just see clinical infiltration or just pilot or QSW. Probably you can still try Venco Cefta. But if you see those ring infiltrate, extensive corneal melting, corneal involvement, then
Yes.
it probably would be a judgment call to jump to rather directly.
No, the decision here is clinically whether it's GPC or
Yes.
GNB.
So we shifted
But
to.
if you have clinical suspicion of gram-negative itself, the question is whether it's Cefta, Imipinum, or colistin.
Yes. So we shifted from Venco plus Kefta to Venco plus Tazac, then instead of Tazac, now Imipinum. That's what I follow. Venco plus Imipinum in the first go.
You don't have time actually in terms of the severity. You can't
Yes.
tell, wait for another 2-3 days
Yes.
and the results come. And
So in RPC, I know they are using piperacillin and tazobactam as
Yes.
the moment they suspect GNB, their first line is piperatazole.
Because the message, the wide message to everyone, even our anti-segment colleagues who actually inject sometimes, because we tell them inject and then send. Agar 1-2 din lagenge to, they still Venco and Kefta. They still stick. I think we need to change that.
We need to advise them.
Yes.
And,
Thank you.
Thanks a lot, Dr. Rajiv. With this, we come to the end of the session. I would like to thank all the speakers and panelists for taking out time for this session, and for the audience for coming in this morning session to attend it. Thank you so much.
Thank you. And Ritesh, what about a photograph?
Yeah. Can we have a photograph, please?